Greetings from Tennessee. Although I am unable to join you in person today, I am glad to share information with you via video. My name is Loraine Swanson. I began my career as an early interventionist, but discovered public health when I accepted a position as the first family consultant for the state of Wisconsin's Children and Youth with Special Health Care Needs program back in 2000. I have now worked for over 20 years planning, implementing, and evaluating MCH-funded programs in 2 states, had leadership roles at 3 national TA centers, and now serve as a public health analyst with the Maternal and Child Health Bureau in the Division of Services for Children with Special Health Needs. I support public health agencies and their newborn screening partners who are implementing the complex system components of the heritable disorders in newborn and children programs. Specifically, as a project officer for the 7 regional genetic networks, which includes SERN, your host today, the National Coordinating Center and Family Center that supports them, the Newborn Screening Family Education Program, as well as the newly funded State Newborn Screening System Priorities Program, referred to as NBS Propel. In my spare time, I'm supporting the implementation of the Blueprint for Change in a variety of ways, mostly focusing on supporting system performance measurement. And I'm here today to talk with you about the Blueprint for Change and what it means for HRSA and our future programming. So let's start with the bigger picture. The Maternal and Child Health Bureau released their strategic plan in 2021. The plan was designed with the input of many stakeholders and will guide MCHB's work for the next decade. The strategic plan includes 4 focus areas of access, equity, workforce capacity, and impact as the pillars to achieving the vision of an America where all mothers, children, and families are thriving and reach their full potential. The Blueprint for Change for Children and Youth with Special Health Care Needs is specifically designed to implement the MCHB plan for children and youth with special health care needs, who I will call SHIN. So what is the Blueprint for Change? It's a framework that was developed by the division specifically for the field to improve the system serving children and youth with special health care needs and their families over the next decade. This graphic represents the 4 critical focus areas of the blueprint: access, financing, quality of life, and health equity. We will touch more on them in a few minutes. This graphic purposefully shows the intentional connection and interdependence of the 4 focus areas. You can't have one area without the others, and all of them serve to support our vision. What we heard from families and experts in the field was that the vision is for children and youth with special health care needs to enjoy a full life from childhood through adulthood and thrive in a system that supports their social, health, and emotional needs, ensuring dignity, autonomy, independence, and active participation in their communities. Or more simplistic, every family is able to get what their child needs so that they can play, go to school, and become a healthy adult. Incorporating the voices of those with lived experiences into the systems that serve them is a guiding commitment of HRSA. As such, the vision and the critical areas were developed in collaboration with self-advocates, children, and their families based on their priorities. So the division in the Maternal Child Health Bureau serves SHIN who are at increased risk for chronic physical, developmental, behavioral, or emotional conditions, and who also require health and related services of a type or amount beyond that required for children generally. About 20% of children need more therapy or health care than other children, and they make up the category of SHIN. Most SHIN have conditions like asthma, allergies, ADHD, anxiety, depression, and autism, but there are 13,000 more conditions, and most of them are very rare. We group them together in the category of SHIN because they tend to have more in common with each other, such as needing to go to the hospital or get other care, more than non-SHIN children. And so we often design policies to support SHIN and their families across different diagnoses and conditions. The history of SHIN is important to understand the blueprint. In some ways, the blueprint started in the 1980s. For decades, MCHB has been taking a leading role in developing frameworks to strengthen the system of services for this population and partnered with federal, state, and private entities to advance policies and programs. The concept of SHIN started in the 1980s when physicians and families began to say that we should think of SHIN as a group deserving special attention, rather than only trying to help children one diagnosis at a time. They argued that we should think about the system of care for all SHIN. So the definition of SHIN was established in the 90s, and we began developing how well SHIN and their families were doing in the early 2000s. In 2010, MCHB created Envision 2020 to guide our strategy to advance and strengthen the system for SHIN. The 6 core components of a well-functioning system, the standards for a well-functioning system, and care coordination have all been developed as part of these past efforts. We are not forgetting these. The blueprint builds on them while intensifying our focus on the expected outcomes from a well-functioning system. The process to develop the blueprint started in 2019 and included collaboration with many stakeholders, including children and youth and their families, healthcare professionals, public health leaders, researchers, and more. In 2019, a steering committee of experts came together prior to COVID, but then because of COVID, the work really evolved. There was a summit held in the fall of 2020 with over 150 participants attending virtually, followed by listening sessions in the 4 focus areas, a public request for information where we got feedback from over 70 stakeholders, all of which was incorporated into the final blueprint. 2021 brought writing groups that were convened to write the 7 blueprint articles that culminated in the release in the American Academy of Pediatrics supplement on June 1st of 2022. People with lived experience with chronic conditions or family members of SHIN were included in every writing group. The blueprint was published, as I said, in June of 2022, included an introduction followed by 7 different articles. The first article is the Blueprint for Change that provides a rationale, guiding assumptions, principles, and strategies to achieve our overall vision. A second article describes the size and characteristics of the SHIN population using the most recent National Survey of Child Health data. Then we have the article Progress, Persistence, and Hope, written by MCHB's Associate Administrator, Dr. Loraine, which describes the public health role in building a well-functioning system of services. The final 4 articles cover the 4 interdependent focus areas of health equity, quality of life, access to services, and financing of services. Each of these 4 articles include a vision, principles, and recommendations for the field in research, policy, and practice. And again, all of these focus area articles have families and persons with lived experiences as authors. And so here you'll see what the 4 focus area visions are, so that you can understand better by what we mean when we talk about quality of life and access to services. And here when we talk about health equity and financing of services. So what is new in the blueprint? MCHB has been addressing financing and access to care for decades, and although we've made progress, we heard loud and clear from families, clinicians, and other stakeholders that we still have work to do. The blueprint has a specific emphasis on quality of life and equity. Families and youth told us that it is fine to measure healthcare processes such as vaccination rates and hospitalizations. However, they also wanted us to include outcomes that matter to families, such as participation in community and school, kindergarten readiness, ability to read, healthy weight, graduating high school. Furthermore, we all agreed that we should be working to make sure that every child is thriving. The vision is all SHIN have a fair and just opportunity to be as healthy as possible and thrive throughout their lives, and the service system prioritizes quality of life, well-being, and supports their flourishing. We know that this is not always true for historically underserved communities, and we want to make sure that we're thinking about children who live in rural regions, families with limited English proficiency, populations defined by race, ethnicity are all included in our expectations. Because our language can sometimes be abstract, we also developed a plain language version of the key blueprint goal. Notice how these words are simple but capture fundamental concepts. If equality is every child getting the same amount, then equity is meeting the child and family where they are. This definition comes from Tawara Good at Georgetown University National Center for Cultural Competence, and it really means addressing challenges of different underserved communities. Note that child thriving includes a successful transition to adulthood, and not just regarding healthcare. We want adults who are healthy, participate in the community through work and other meaningful activities, and live as independently as possible. Lastly, given that there are 13,000 medical conditions with many different potential outcomes, we think that caregiver and sibling well-being may be one of the best measures of a well-functioning system of care. When families don't have to worry so much about getting the medicine or therapy their child needs, they are happier and healthier and able to work and participate more fully themselves in the community. So how is the blueprint changing what we do? We are increasing our focus on measuring what matters. Measuring what matters means looking at examples of universal measures that could be adapted by grantees, Title V programs, health insurers, and researchers, not just the immunization rates or hospitalizations, but outcomes that really matter to families and society more general. The idea is to have everyone aiming at these outcomes as the important North Star. We want to have condition-specific measures. We understand those will vary depending on the circumstance. We'll talk just a minute about language outcomes for deaf or hard of hearing children as an example. We also want to make sure that fewer children with bleeding disorders have joint bleeds, which correlates with function. This is particularly important for children with autism or intellectual disability for whom some universal measures may not be applicable. And we want to have measures at a populations level. Taking a systems level approach is population health 2.0 that is the best way to have an impact and reach large populations to see what we can do at a systems level. For example, a grantee could use limited funds to pay a family member with lived experience to be a family navigator for others. Or the grantee could gather stakeholders and think about a systems level solution, such as health insurance payments to family navigators, just as any care coordinator or healthcare professional would be paid. This could lead to widespread availability of family navigation services in a sustainable model, and that's what we'd like to reach. We also want to look at equity. If the number is the quality of life or condition specific measure, then we want to aim for targeted universalism. All organizations should plan, track, and explain their role and have these universal measures in our NOFOs and across different aspects of measurement, including healthy people, CDC's outcomes, and the National Survey for Children's Health. So here's one specific example of how measuring what matters is going to help us implement the blueprint. Nearly every child in the US gets a hearing test in the first month of life because about 1 in 1,000 are born deaf or hard of hearing. When detected early, these infants can get interventions such as hearing amplification, cochlear implants, and visual approaches to language such as American Sign Language. Without such treatment, it is very difficult for deaf and hard of hearing children to learn to use language to think and communicate. In December of 2022, Congress passed the Early Hearing Detection and Intervention Act, and President Biden signed the bill into law. Our division funds every state to help make sure that the system works. And historically, our state EDI programs have focused on the first 6 months to ensure that every child is screened, that positive results are confirmed, and that infants found to be deaf and hard of hearing are connected to treatment by 6 months of life. We often measure 1, 3, 6, the percent screened at 1 month, diagnosed at 3 months, connected to treatment at 6 months. The ultimate goal of this newborn screening program for hearing is to improve language outcomes. So we should be considering whether deaf and hard of hearing children are achieving language milestones. The ability to use language, ASL or spoken language, predicts reading, communication, and many other outcomes that families and societies think really matter. So our EDI state program should continue to start on the left of this diagram to ensure that every child is screened and gets a diagnosis, as they have been. But there are other steps that are critical, and just begin with the first connection to early intervention. Are we supporting the family, connecting to them to medical care, and ensuring a language-rich environment, both in the home and in early care and education centers? In our approach to implementing the blueprint, we are asking states to start tracking language outcomes at age 3 to match the federal legislation. We're not forgetting about the 1, 3, 6. However, we know screening and initial connection to services is just the start of the family's journey to ensuring that their child is able to play, go to school, and become a healthy adult. Measuring what matters means we are asking states to report the percent of all 3-year-old children who are deaf and hard of hearing in their state who have language scores in the typical or average range. The goal is to increase this percentage each year, getting as high as we can. A good way for states to do this is to gather all the key stakeholders: families, the deaf community, audiologists and speech pathologists, early intervention specialists, early care and education leaders, Medicaid, and other insurers. They can help map out how this pipeline is supposed to work in their state and where they think the key leaks are. They can devise a plan to address those leaks, then meet again in a few months or a year to see what progress they made. This is what we mean by improving the system of care and holding ourselves accountable. EDI state coordinators don't need to do everything themselves. They can help drive this process by gathering the data, convening key folks in their state, and the federal government has to help by making it easier for state systems such as Medicaid, Title V, and Part C to work together. A critical step in this process is to disaggregate the data. That is, every state should also subdivide the data according to groups that are historically underserved in their state, whether that is rural, limited English, by race or ethnicity. The best way to improve the overall percentage of deaf and hard of hearing children with typical language scores is to identify which children may be doing better or worse, then adjusting the state strategy as appropriate. This is good old-fashioned public health, and we know that it works to help every child. The figure from the previous slide makes the pipeline pathway look relatively simple. In fact, policy in our country, like most places, was built up piece by piece, with each generation of leaders creating programs to solve specific problems at the time based on the best evidence and political reality. So Medicaid, Part C, state newborn screening, housing, nutrition, and economic support programs all have their own complicated history and sets of rules. The resulting systems of care can appear to look more like the right side of this slide. One of our key roles as health policy leaders is to try to make the system a bit less complicated, or at least create a simplified diagram map that focuses on the key connections to make the systems workable for families and their children. We have funded a new national TA center that will be housed at the American Academy of Pediatrics and will support implementation of the blueprint in the field. Together, we will ensure implementation of the blueprint is inclusive of family partnership and leadership throughout the 5-year scope of their work to streamline the pipelines. Another example that may be more familiar to all of you is newborn screening. Very similarly, we have funded different components of the program to look at screening timelines, receipt of specimens, timing of diagnosis. And what we really want to move forward with is looking at the long-term follow-up components of newborn screening so that we can look at how children are thriving at 3 years of age if they are born with the heritable condition. And in that vein, there has been a great focus through the years of looking at different measurements, but little data about the long-term outcomes for children, including receipt of services such as genetic services and developmental testing. And yet we just don't want to know if they were tested. We want to move beyond that. So we really want to know, are they thriving at 3 years of age? So together with our CDC colleagues, we are beginning to imagine what a system for long-term follow-up look like. We're looking at who holds the data for the NBS lab results, who is holding the data for the notification and short-term follow-up steps, and how do we reach a bucket where we have longitudinal clinical care data so we can really see if children with newborn screening found conditions have received the right treatments in the right timelines. So the blueprint is driving investments in programming of the DSHN to focus on strengthening systems that are built around the needs of families, that support access, equity, and integration, that address upstream and downstream factors of equality, and that measure outcomes that are meaningful, especially to children and families. With the leadership of Dr. Jeffrey Brosco, who joined our division last September, we are hoping that the blueprint really is the next step for advancement, and we see systems continuing to improve so that at some point in the future, we hope families say the support they received was delightful. You can scan the QR code in your copy of the slides to easily be connected to more information about the blueprint and all of the different articles, as I mentioned. And as always, we encourage you to connect with HRSA and be part of our Blueprint for Change champions. Thank you so much for your time and attention today, and we look forward to any questions you may have.